All right, guys, everybody ready? Thanks for everybody's patience. We are trying to test out. We want to make this a CEU course. So we're trying to Zoom record it, but make sure we have the slides associated and also have the slides up above. So just bear with us on some technology stuff. So thanks so much for everybody's patience, but I'm going to turn it over to Marcelo. Marcelo is our scoliosis guru and it's going to give us some really good information. So whenever you're ready.
Yeah, so it's...
Thanks for being here, by the way.
Let me just start here from the... Okay, it is recording.
Yeah.
Okay, yeah, so... My name is Marcelo. I graduated in Brazil 20 years ago. I worked most of my time when I was in Brazil with sports, professional athletes, soccer players, basketball players. Now, when I moved to the States after getting my credentials here, I started working in different clinics, then about sports medicine. And at some point, that was like 3-4 years ago, I decided to challenge myself and treat something that nobody else treat. And then somehow I picked scoliosis. Yeah, I had this patient, he was a runner with scoliosis. And at some point, I didn't know what to do. I just, how can I make this patient better? Okay, I decided to search for courses or how can I understand scoliosis better to get this guy running. And so that's how pretty much started seeing scoliosis. First thing, when you talk about scoliosis, everybody says Schroth. Came for Schroth. Schroth is a more like a popular name, named after Catherine Schroth, who created the method. We are not supposed to say the word Schroth unless you took the Schroth course in Germany. It's like a Graston thing. So we call physical therapy scoliosis specific exercise. It's written physiotherapeutic because it comes from Europe. They use physiotherapeutic and not physical therapy. So it's tried not to change. And they call PSSE, which is physical therapy scoliosis specific exercise. And what, I don't know you, but when I was back 20 years ago, learning scoliosis, I have a curve to the right, curve to the left. In reality, it's only 3 planes. In the frontal plane, which you see the right and left. On the transverse plane, we have a rotation of the vertebrae. And on the sagittal plane usually have a flattening of the spine. So if you see it from the side, image, something you see instead of the normal kyphosis lordosis is more a flat back. Sometimes even you have a kind of kyphotic lordosis and a lordotic kyphosis, if that makes sense. It's pretty much inverted. We can kind of see in the next picture. You almost see a lordosis in the thoracic. So you have a flattening of on the sagittal plane, rotation, and in the frontal plane, you see the S or C curve. So on the next picture, what you see in the X-ray is that pretty much the curve, right and left, in reality is like a staircase. We see the right and left, but you have the rotation. And if your spine just going to keep growing, you're going to see, we just see like a staircase just going like a spiral. One thing that is very debatable, how much is accurate, how much is valid, the Cobb angle, but is what we have as a standard goal to measure the scoliosis. Under 10 degrees on the Cobb angle is not scoliosis. It's a scoliotic posture, it's a deviation. We all have some sort of deviation. So under 10 degrees of Cobb angle, the diagnosis of scoliosis should not be made. Over 30 degrees, the risk of progression in adulthood increases. So let's say you have like 15 degrees, okay, it is official scoliosis. When the growth plates close, is more likely to be stable, to not progress in adulthood. And over 30 degrees, there is a risk of progression in adulthood. Over 50 degrees, there is a consensus that's almost certain that scoliosis is going to progress in adulthood. All this data is from the SOSART. SOSART is the international society that studies scoliosis. So the first guideline that the SOSART released was 2016, 10 years ago. So it's still like still a baby. It's still a brand new this approach for scoliosis. And what do we have as a goal of when you're gonna treat scoliosis? One, to stop the curve progression of puberty on this teenager. In adults, it's more like symptoms management, and or possibly reduce the curve, decrease. To prevent or treat respiratory dysfunction, because now you know one side of the rib cage is going to be collapsing, it might compress the lung even higher. Prevent or treat spinal pain syndromes. Then the question, is scoliosis painful? Scoliosis is the deviation of the spine. What hurts? There is a risk factor to have bulging discs, to have arthritis, to have all those other spinal conditions that cause pain. Scoliosis is a deviation of the spine that adds another risk factor to the back. Usually I say, when it comes to back pain, it's not one factor, it's a lot of factors. Scoliosis is one risk factor on top of everything else. To improve aesthetics via postural correction. This can be a little bit tricky. SOSART, they did like a while back, a huge survey in teenagers. And improve aesthetics was the #1 concern, and especially teenagers. It is not painful at that time. There's no functional limitations. They're not worried about functional limitations later on in life. They worry about looking good. Here in the States, it's tricky because you cannot use it as a goal because insurance might deny. But with the patient, it's something you need to keep in mind because that's how they want it. They want to look good for friends, for possible partners. Of course, not gonna use that as a goal for insurance, but it's something to keep in mind with the teenagers. Okay, and the guidelines, mostly this for teenagers. What we approach to use to treat scoliosis. Between the 0 and 10 on the Cobb angle, less than 7 degrees of scoliometry, just observation. Just keep eye. The doctors usually ask the kid to go to the doctor's office every 6 months to get a new x-ray, see if it's progressing or not. If it's under 10 degrees, just observation. 10 to 25 degrees is PSSE, sure, or specific exercise for scoliosis. 25 to 45, brace and shrug or PSSE. 45, 50 above, it's surgery. There's a consensus that when you get to 45, 50, the curve is more likely to progress. And so then it's surgery. A little bit of history. In the 70s, we have this first Milwaukee brace. You can see it only addresses elongation, that one plane, the neck, pretty much pull your neck up, that's uncomfortable. It was a failure, didn't work. In the late 70s, 80s, Boston brace came up with a better version, but still only treat one plane. Yeah, you can sort of see in this picture right here, it is flat, pretty much is straight, so it doesn't treat in 3 dimensions. Then today, what you have the 3D scoliosis brace, Boston brace evolved. So Boston brace today is using this. It's customized. Now you need to measure. They send it to a lab. They're gonna print a 3D print of the patient torso, and they're gonna mold it and create brace personalized for that person. And you can see this side is a little bit, there's more pressure tension in here. You're gonna see later on, they create what kind of called diagonal tension line. We see kind of recreating the lordosis and kyphosis here. And from this view, you can see that the end is different than here on both sides, which works the rotation. So the brace, you work on the 3 planes, which is way more effective than the old braces. From the SOSART, to be considered PSSE, physical therapy scoliosis specific exercise, we need to follow these 4 principles. 1, autocorrection in 3D, or which means the correction needs to be in the 3 planes. It needs to be functional. We need to be able to apply those corrections to the daily living, and then stabilize the corrected posture and patient education. It's not just, okay, you're gonna treat it and then you go home. They need to understand how it works, then the principle be able to replicate at home, because it's something that they need to do for life. It's not, came 8 weeks and you're good. Pain is over, you're good. It's something to do for life. So we need to work more like a coach for them to understand the concept and be able to replicate at home. For teenagers, usually I bring mom and dad to the session because a teenager won't be doing this exercise at home. So you need to bring family to the session. So a little bit here is the 7 recognized schools by the SOSART to address scoliosis that follow on all these guidelines. Lyon from France, Schrott from Germany, Cias from Italy, the Barcelona Scoliosis Physical Therapy School from Spain. Most of the PTs in the United States follow the Barcelona Scoliosis Physical Therapy School. Today is known as a RIGO concept. Double Med from Poland, Side Shift from UK, and FIT from Poland. There's a few other schools that are still not recognized, but they are in process of being recognized. There is another one from France that uses the term Schrott as well, and the S4D from Brazil. They're in process of being recognized. They all like based on Schrott, but they follow these guidelines. Assessment, what do you do? First, you need to decide if it's structural or postural. And then you're gonna do clinical assessment, radiological. The major difference between structural and postural? Pretty much structural, when the scoliosis is fixed, we cannot reverse the curve. Posture, if you have like a scoliosis posture, you do the Adams test and the curve pretty much disappears, that's posture. And it's not like a true scoliosis. Probably the person is hyperflexible, cannot hold the posture. You have more like a scoliotic posture than actual scoliosis. Functional tools, what you use to assess, you can use Oswestry to assess pain, but we use the SRS-22, which is a questionnaire specific for scoliosis. Clinical, we have some scoliosis specific tests and general PT. You can use our general PT knowledge if there are symptoms, that's lumps, flexibility. Image, we're gonna assess the Cobb angle and research sign. Research sign is a sign that you can see either the research signs on the hips. You see how much of open growth plate they have. You can sort of have an idea how much years or how much they have to grow. And based on that, you can assess the risk of scoliosis progression. Some specific tests for scoliosis, you can measure the height in a sitting and standing position. You divide it, you get a number. In like 6 months from now, you measure again. If that number, the sitting divided by the standing, there is a huge gap, might be indicated the scoliosis is progressing. Because if in a sitting position, you measure, like say, 10 inches in a stand, whatever. And then you measure again in a seated position. You got the same 10 inches, but the person grow, have longer legs. The difference between the torso and total height will be different. That can be indicated as scoliosis progress. And now this trunk height and wingspan, you measure that. The trunk height and wingspan divide, you get a number. 6 months from now, you can measure again. You have the same, pretty much the same number, the same result for this division. This scoliosis is probably stable, but it's pretty much, if the trunk's not growing and the arms are growing, the scoliosis is getting increased. The curve is increased because it's crushing down. And then the deformity in the frontal, horizontal, sagittal plane. Trunk imbalance. We project a laser line from the sacrocental line to T1 and see how much that deviates. That's one goal that you set for insurance. I want to decrease the angle of thoracic inclination from 2 centimeters to 1 centimeters. You can quickly demonstrate that if you have a volunteer. Okay. Usually I'm doing a seated position because take the legs out of the way, the leg line out of the way. You're going to be standing just to be easier to see. So I'm going to find the sacrocentral line. Put a dot right there. And T1, T, and project. So you can see T1 is offset to the left. It's okay if I talk about it.
Yeah.
Gabby has a minor scoliosis. So imagine that. Try not to move. It'll be roughly 0.8 to 1 centimeter. So one of the goals, so this is what we call imbalance. Gab is leaning to the left. So one of our goals is to bring Gab to a balanced position to be as aligned as possible. The curve is to be there, but now it's balanced. The weight is distributed evenly on both sides. Because if Gab starts to lean, there'll be more weight bearing on this side. That can lead to more strain in the SI joint or in the hips or something. So that's one of our goals, is the ATI, or angle of thoracic inclination. Adams forward test, classic test that we all know. Can you touch? You have a scoliometer and a little bit less. And gonna see the inclinations. I have a 2 or 3 degrees here. And a 5 degrees here. So there you measure the rotation. Yep. All right, you're good.
Did it go away or?
Yeah. For now.
Thanks, Gavin. Thanks, Gavin.
In leg length discrepancy. Quite often, now not as much, in the past, a lot of doctors, you're right, leg's shorter. Let's put an insole there. However, most cases, the right leg's not shorter, the leg length is the same, but because the rotation scoliosis, the curve is bringing the right hip up. So the leg length is the same, but the scoliosis is bringing the right hip up or left. Right's more common, and forward. So we don't put insoles anymore. You want to try to bring the hip down instead of put something to keep in elevate. So the goal is to bring that down instead of actually put an insole. Of course, if it's a true leg length discrepancy, then yes, then you put an insole. Okay, this is, let's say, for a non-scoliosis PT, when to refer to PSSE. If it's non-structural, if it's postural, it's okay to treat with general PT. Doesn't need to be shroud. Adams test, negative. Now, we did the Adams test with Gabi, 5 degrees and 4 degrees. Sideband test is negative. Sideband test is, you can see the spine, you just side bend. If the curve disappears, you see a 1, the round C is negative. It's just scoliotic posture. If side bending, you can still see the curve, that's structure, that you can refer to PSSE. And Kobe angle to less than 10 degrees. Again, less than 10 degrees is not considered scoliosis. We treat scoliosis from inside out with breathing, and the collapse of 10 degrees or less, it's so little that just doesn't make sense. Just doesn't, it's not effective. And structural, Adams test positive, sideband test positive, Kobe angle above 10 degrees. And again, over 30 degrees, the chance of progression in adulthood increases. So keep in mind, it's not painful. We have a 40 degrees. It's good to do, even though it's not painful, good to prevent to get worse. Here is the classification that we have for the Rigo concept. Pretty much these 3, 4 types is going to define the strategies that we're going to use to derotate, elongate, and expand the spine. Finding neutral pelvic position. Do you guys haven't had like any patient or something, they are good squatters, but not good at deadlifting, or vice versa? Do you guys have an idea why? No? Yes?
Good squatter, but bad at deadlifting.
Yeah, good at squat, bad at deadlift, or good at deadlift, but bad at squat. Okay. A little bit classification. What we call pelvic tilt, anterior pelvic tilt, posterior pelvic tilt. Doctors who treat scoliosis, they have a different concept of pelvic tilt. That's anteroversion, retroversion. What they see as a pelvic tilt is a numeric number that's fixed. No, you can't change that, which is the angle between the midpoint of the sacrum to the head of femur. And then a 9 angles, line a 9 degrees angle, that's your pelvic tilt. That you define the sacral slope. Can I put the next one? So this guy has a high, low pelvic tilt, which is this angle here, which has a low sacral slope. This guy will be a good deadlifter, but a bad squat. If the guy squat, it's gonna arch really way sooner than the other people. And this will be a good deadlift, squatter, but bad at deadlift. Because the sacral slope, he needs that high lordosis because of that. the lower back needs to follow the angle of the sacrum, and you have those high lordosis. We can change that. That's a fixed number. What happened away in the past, they're doing surgery. Should go back one more. Roughly, okay, the most people has like 45 degrees of lordosis. So, okay, we need to do a spinal fusion. Let's fuse the spine at 45 degrees. And some people came out with surgery like this. They could not be upright. If they upright, the knee will go in, or vice versa. Get the fusion 45 degrees average, it'll be right here. If they try to be upright, the hips will open. As this extreme, a very low pelvic tilt or very high angle pelvic tilt, they're pretty much the doctors today, they're taking consideration the pelvic tilt, not just average normal, the 45 degrees. Regal concept, general principle. What we're gonna do? Learn the best 3D posture self-correction. Gonna try to align the spine, derotate, elongate, and expand to the most aligned way possible. Learn to reshape, expand of collapse areas, and tension of the areas that's expanding. Pretty much you're gonna control the internal volume. You're gonna treat from inside out. Learn to activate muscles to keep the stable 3D correction. We do that with short breathing, which is breathing through your nose, expand, breathe out through your mouth, pursed breathing, to try to engage every single little muscle in your core, intercostals, everything, try to stabilize in that position. And integration. Integration means after the exercise, take 30 seconds to listen to your body. What changed? I feel open, I feel expanded. What I get the most, I feel more open, I can breathe more, I feel taller, I feel expanded, I feel lighter. Yes, because on the side that's collapsing, all the intercostal muscles, they're short and they're tight. They need open, they need to activate. On the other side, they stretch. So they need to engage tension. And when you place the spine the most aligned way possible, those muscles they weren't work, they need to work. Sometimes they feel sore because they're just breathing, because now those muscles need to work. Yeah, so pretty much you're gonna place the spine in the most aligned way possible and use breathing to expand and stabilize the position. Okay, Gabi, you can eat.
Sorry.
Okay. You're gonna face that way. You can see that.
Oh.
So the first principle, actually, gonna jump in the slides. So the first predefined strategy, you're gonna find neutral position, which is, if you're doing the cat and cow, when you're doing the cat, you engage abs. When you're doing the cow, you engage back muscles. You wanna find a neutral position that will engage the least amount of muscle possible. We all have different neutral positions, so it's not standardized based on that pelvic tilt. So when you do a pelvic tilt, anterior or anteroversion, rotaversion, you find a sweet spot in between the two, the least amount of muscle out and back. Okay, so we got the first predefined strategy, then neutral position. Then the second is work on axial plane, traction, elongation. In this case, you're doing standing on a gap to get taller, as tall as you can. We can do it in different positions. We can use the dowels, we can use the stall bar. Stall bar.
Yeah. Has all the like rods.
So in this case now, just try to get taller. Get this. And then the third predefined strategy, work on frontal pain. We're going to create a diagonal tension line. So, and now, Gabi, it's a 4C. So this was a little bit to the left. Yes, very mild. Yes. You want to bring the right hip down and back. So we're going to put a bit of pressure on the right leg down and move back. Here, I'm going to try to bring up to open this curve right here. Imagine a curve right here. Up. Here, tension is expanding here. So on a tension, close, forward, because it's moving back. Here, you're going to open, expand, back. Get taller, then breathe in. Breathe out. Breathe in. Breathe out. Pretty much you place the most aligned way possible using breathing to stabilize. We can help open this by, oh, sorry, it's okay. By lifting this shoulder.
I hurt myself.
Okay, come down. Yeah. Imagine if this hand is out. That would be here. So it's a basic snap pretty much standing position. We can make it a lot more fancier, adding some props. So this pretty much is in a nutshell how the strategies. Some curves you're gonna use the fourth and fifth, which is, for example, if there is a huge shift to the right, I want to find a neutral position added tension here. Bring my hand to the left. More. Tension with my hand until I can bring that back to normal. And add tension forward, up, down, open, expand, back, breathe in, breathe out. So pretty much based on the type of curve, you're gonna use different strategies to bring the spine to the most aligned way possible, and then elongate, derotate, and expand. Ultimate goal, try to apply all those corrections, those strategies to our daily activities. Pick up something from the floor. Like classic example. I need to pick up something from the floor. Instead of falling into the curve, I'm gonna get the corrections, stabilize, and then use it to see a proper squat. Okay, here's the. Okay. Thank you. How are you doing? Fine. So this patient, 13 years old, female, denied family history, overall health, no physical limitations, no pain. Date of first physio appointment, and March 18, 13 years old, no pain, no prior treatment for scoliosis, using brace, the Boston brace 3D, doesn't qualify for surgery. Here is the Adams test. Now you can see then the rotation. Let's go next. The angle of thoracic inclination, how inclined is to. So there is a 9 degrees of rotation. Yep. And thoracic 11 degrees of rotation lumbar, 1.5 degrees is thoracic angle of thoracic inclination. Rating score, this patient is not hypermobile. There is no true leg length discrepancy. Core was 3 out of 5. The sit-up test, the bearing score is 6 seconds. 3 centimeters of expansion. Based on research sign, Cobb angle age, we can calculate the risk of progression. She had a 53% of progression. Cobb angle 32, lumbar thoracic 27. Nashimo is another measurement. You can see next ray to see rotation. Research site 4, and the type is a 4C. This is before and after. So pretty much 3 months we decrease the angle of thoracic inclination from 1.5 to 0.8 centimeters. Supine to seat test, we did not do any strengthening. She went for 3.5 to 5.5 on the supine to seat test, just having a little bit more alignment. Angle of thoracic inclination at rotation, 11 to 9, 6 to 5. Cobb angle, it decreased thoracic from 27 to 19, lumbar 32 through 26. Rib cage expansion from 3 centimeters to 4 centimeters. She grew 1.5 inches in 3 months. And the risk of progression decreased from 53 to 19%. And here is her X-ray. Lumbar 32, and you can see, especially here, you can see that now I have 19 degrees and I have 27. And here 32, a little bit less, than 26. So it's almost getting rid of brace. Research 4, she probably has a little bit more, a year of growing something. Now, research 5 is when the growth plates fully grow. You guys know Usain Bolt, the fastest man on the planet. He has scoliosis. So his words, when I was younger, it wasn't really a problem, but you grow and it gets worse. My spine is really curved back, it makes an S shape, but if I keep my core and back strong, the scoliosis doesn't really bother me, so I don't have to worry about it as long as I work hard. The early part of my career, when I didn't really know much about it, it really hampered me because I got injured every year. That brings the next sketch. Can a scoliosis patient do exercise? Yes. Can run, can go to the gym, can lift weight, can do pretty much anything. Is it good to add a little bit of tension, keep your core strong, and doing something specific for scoliosis to minimize? Yes. But there is no concerns about doing sports. Questions? Yeah.
I was just gonna say, I just have a question for when we're referring people to you. I know, like, if we're sharing a patient, and just so that we know what to tell the patient when we're talking to them about like what the process is gonna look like. Is it something that you need to see them like once or twice a week, or is it something that like, you give them things to work on for like 2 weeks and then we kind of tag team with the strengthening, or is there some, like, what does it look like in terms of like the like start to finish with you? Do you see them twice a week? Do you see them?
Good question. First, there is a lot of research showing strength, normal exercise, and short are the best compared to just exercise or just short. So normal PT, normal strength, and short is the best approach. Short or a PSSE. The goal for us to be a coach and teach them the concept. Ideally, they need to do it at least 30 minutes or around 30 minutes at home 4 to 5 times a week. Because you have gravity crushing us down all day long. If you do 40 minutes for a week and do nothing at home, nothing's going to change. So they need to be at home, do at home 4 or 5 times a week, about 30 minutes. So usually I start once a week for 2 months, something. When they start getting the concept, every other week, every month. I have some patients coming now every 3 or 4 months just to check every month. So we start once a week usually, and then decrease as they get comfortable doing at home.
Are you doing, like, is it something that you would want us to try to see them like once a week and then you see them once a week, or are you giving?
That's
them
perfect
some
for
of the, is that okay?
Yeah, then can like once a week having a more strength and stability or core, whatever guys work.
Okay.
And then the other week, do something specific to do it. It's perfect fine.
Thank you.
I was gonna ask Marcelo.
Yeah.
Typically when patients call, they're like, I have scoliosis and I want to work with a therapist that treats scoliosis.
Mhm.
So we refer them to you. Are you getting, I know like all these measurements and stuff. are you getting patients in with back pain that you're saying, you know what, I'm going to go through all these tests and diagnose like scoliosis, or are you getting people that come in with a diagnosis beforehand? You know what I mean?
Most of they come diagnosed scoliosis diagnosed beforehand. And most they're seeing the doctor, we have scoliosis, you need to see a shot, that therapist. But occasionally you have somebody showing up who doesn't know that they have scoliosis and you see at the clinic.
What might lead you to think, like, what would somebody be complaining of? Is it back pain? Is it like saying, you know, my hips just feel off, my leg feels, this leg feels?
Yeah.
What kind of leads you into like looking at?
Good question. So most of the scoliosis, they're not diagnosed, let's say, at the doctor's office. If it's a teenager, it happens at school, doing physical education, when today the physical educators, they're getting more educated to screen and see if they can pick up that early, because scoliosis is not painful in teenagers, it's a silent disease. Or when family is going to the beach or to a swimming pool, the kid take the clothes off and mom or dad, oh, something doesn't look quite right. They take to the doctor. But if it's a teenager, it's not symptomatic. So it's when somebody see that's not quite straight. If they miss that as a teenager, as an adult, the easiest one is the Adams test. You just ask them to the Adams test, see if you see that they're inclined, it's less side lobe. You can find this on Amazon, is very cheap. There is some apps on iPhone, phone, the scoliometer. If you see more than 7 degrees, refer to a doctor or to a short PT. If it's less than 7 degrees, 3, 4, it's just very mild. Just keep your eye on it, just observe it. But the easiest one is the Adams test. Shoulders uneven, quite often that is easy to pick up.
What do you say that? Because I remember as a kid and having to have school physical, you have to have an test. I remember having to do that.
Yeah.
So they're doing a fairly good job at schools trying to pick these early stage.
Is a lot of the equipment for this, like for this stuff that they can do at home, or are there certain things that they can, like they need some equipment in the office to do with you, or is it a lot of it? Is there anything that you have to get? Or?
That town bar, it's really helpful, but there is a way to do at home without. Now using the door, using yoga straps, anchor in the door, it's perfect fine. I should have bring the door. I can demonstrate, you have time, some of the positions on the floor, if that's okay.
Yeah.
Then a volunteer, maybe a different volunteer without shoulder.
Josh.
It's okay.
Got roped into that.
So this position can be a little bit awkward at the beginning because it's not like a conventional PT. You do like a bridge, a down, squat. But it's put this in your hip, right here, nice and tight, nice and tight. So, I'm gonna, do we have something? Let me do this. So I want you to be on your knees. You have a yoga block. A yoga block and any one. And anything else like a pillow, yeah. So let's assume is a 4C scoliosis in S. Right hip is going up and forward. We have that T-prong, that thoracic rib cage on the right side coming back, and here is collapsed. So this shoulder is here, this here, and this is coming up. Not pretending that. Okay, so that's what on is. So gonna be on your knees. And rest your head here. No, 90 degrees. Okay. So you have this belt, the strap. pull in that direction. So it's the first strategy. Axial elongation, and you active try to get up. Forward, get up, roll top. Good. Elbows to the side, elbows to the side. In this case, the right side, I'm gonna lift the elbow a little bit. We're gonna lift the elbow a little bit. Okay, so you work on one thing, getting taller, elongation. We're gonna open this. So right hip a little bit away from your rib cage. Yeah, so the lower part of the rib cage up, right hip down, open hip. Good. So here you have that T-prong. You want a tension close. Move down, move forward. So attention, close, down, elbow to the side. Here's collapsing. Want to open, expand, up. Then breathe in through your nose, breathe out through your mouth. So we're gonna combine breathing. Breathe in, open here, breathe here, open, expand, and goes out. Breathe out. Tension, down, close. Breathe in, open, expand. Keep it open, tension, down, close. Right hip away from the rib cage. Roll taller. Neutral position. Fine. Roll taller. Breathe in, expand, open. Keep it open, breathe out, tension, down. So stand up. So pretty much you play those strategies to derotate, elongate, and expand. Common mistake. The curve is here. Let's stretch that way. What's happening here? Huh?
No, stretching one plane.
Yeah, so I might be fixing, you can touch one plane, yeah, but I might be fixing the upper curve. Let's see, open here, but I'm making the lower curve worse. Because I have a concave and convex. So or making the convex better, but the concave here making worse.
Do you start at the core? Do you start at that, build that foundation and work your way up the chain? As far as like correcting here first?
Yes, makes it a bit easier.
Yeah.
You have 4 yoga blocks.
Oh, do we have?
Yeah, you can. Yeah, can stand up.
Three.
Can go there. Thank you. It's a little bit clear how we deal
We could
with.
use the half foam roller as the fourth. I already upstairs to get another one. This is the same. We use this short one.
You should be
going
going
out.
This one's a little higher.
That's okay.
You want this or not? No, as an extra.
Do we have 4 pillows? Do you want pillows?
You can.
Or yoga mat.
I mean, there's a big.
Oh, yeah, choose. There's a foam pad.
Use this. There, you can get the computer here. There we go. Prop on the pavement, next to the computer to. Okay, so this is the block concept. If you see from the back, it's a straight line. If you see from the line, is the hip, lordosis, kyphosis is a cervical lordosis. And scoliosis. So this will be forward and up. This will be here in your shoulders. So this is the 4C. Right hip. Right hip is up and forward. So you're gonna move the right hip down and back. Move this rib cage up. Then you create this force to open here. And then here's your T-prong, the thoracic. When tension, close, forward. Here, open, expand, back. And then we fix a little bit just the shoulder. So it's that concept, derotation, elongation and expansion of the spine and rib cage. So this is pretty much what you did when you're down there. But that's not functional. No, that's not functional. We don't leave that position. But without gravity, it's a lot easier to get all these strategies in practice over and over and over and over. And then at some point be able to replicate that in a standing position in something more functional.
How long do you feel like it takes people to get the like basic position down before you can move them into something?
2-3 months before you get more functional. Yeah. To the point that then pick that from the part, okay? Get all the strategies and pick up something. Pick up something for a cabinet instead of falling into the curve. I'm gonna pick up there. Hold a little bit. I'm gonna get all the cues, right hip down, get out the, and now I'm gonna reach the minor, let's say, subtle change might be the edge that you needed to not pull almost not into something. So yeah, so take like about 2-3 months to get out the concept in that non-weight bearing position, and then you transfer that to something more functional, which is a lot harder. Any other question?
Everybody feel good, scoliosis now?
That burden, you're little.
Things that I have seen, what I have heard from patients, that this patient 50+ degrees in the 60s, she was complaining that wearing a bra was painful. And after almost a year, it took a lot. Just were able to wear a bra without pain. I mean, might seem silly, but that's huge for be able to wear a bra without pain. Maybe a small detail for that person, that's huge. She's in the 60s, so she's getting to progressive scoliosis. Her curve was progressing 3 degrees a year. So the past 3 years, 2 degrees a year. So the third year, the doctor, okay, go see a shrub, a specialist. After 1 year of treatment, we not just stabilize, but you decrease 3 degrees, and the symptoms are way more mentioned, to the point that she can't wear a bra. You not just stop the progression, you have to decrease 3 degrees. So is it perfect? No, but it works.
Any other questions? Well, thank you, Marcelo.
Yeah, thank you, Marcelo. Oh, gosh.
Yeah, so Mike should be sending out a survey and then
Yeah,
certificate.
guys, there's gonna be a survey and a certificate coming around from Mike for CEUs. So just keep an eye out for it. You have to fill